So yes, without further ado, we will go on to our next speaker. And to begin today's talks, I would like to introduce Emilian Popa, the co-founder and CEO of Ilara Health. Emilian, apologies if I have got your pronunciation wrong, and please do correct me if it's not right. He is an Africa-focused investor and entrepreneur. He sees his mission as enabling people to live healthier and longer lives, and he has delivered several breakthrough technologies, and often at a fraction of the current treatment and diagnostic costs. Today, Emilian will be presenting a new model of primary healthcare and how to improve health outcomes in developing countries. Thank you very much for joining us, and you are welcome to start, and I will allow you to introduce yourself again. Apologies.
All right, thanks, Roxy, and thanks, Tatiana, for the introduction. So as you mentioned, I'm in Africa. I'm actually in Kenya, spending most of my time here, but I will start, let me share my screen. I will start to tell you about what I do in Africa. So I'll start with introducing myself for the next 15-20 minutes and introducing Ilara Health, which is the company which I founded just over 3 years ago in Nairobi, Kenya. So as I said, I'm Emilian, I'm the CEO and the founder of Ilara Health. And the person you see here in the first slide is actually Dr. Boniface. And he's actually not a doctor, he's a nurse, he's a clinical officer who runs a small clinic in a place called Kawangware, next door from where I am now, in the outskirts of Nairobi. Kawangware is actually a low-income settlement where most of the people live under $6-7 a day. And Dr. Boniface is trained as a clinical officer who consults and dispenses medicine tablet by tablet to patients in his low-income community out of his small medical center. When I met him for the first time, and I really, just even before starting Ilara, I asked him, Dr. Boniface, what would you need to better do your job? And he immediately answered, I would love to have a small lab in my small medical facility. And this was an aha moment for me, because since then, I visited more than 500 health clinics and community pharmacies, and the quality is extremely poor. When you go to see a doctor, whether you're in London or in Kiev or in some other places in the world, in 2 in 3 cases, you probably need to do some kind of diagnostic. So, the theory says 70% of clinical decisions require some form of diagnostics, be it a blood test, be it a saliva test, be it something else. But there are more than 500 million people in Africa, which is almost half of the population today, who struggle to access or afford a simple blood test. And who cannot access and afford the blood test, and the death because of this are actually even bigger because of the quality of care, because of the lack of quality of care. So we always say that there are 5 million people or 3 million people dying every year because of the lack of access to care in low to mid-income markets, but there's 6 million people dying because of the low quality of care. And the low quality of care meaning there's no insurance, there is no proper access to care, there's no proper clinics, and no proper doctors. As I said, Africa has 1.2 billion people today. There are 54 countries, but actually at Ilara we look at 5 key markets in Africa, to serve over 100 million people, and access over 200,000 medical facilities. So Africa is extremely fragmented. Kenya itself has, if you think, 20,000 small medical facilities. So think of UK. UK has, let's call it 5,000 proper doctors and maybe 1,000 proper hospitals. Kenya has 20,000 primary care facilities, but all of them look pretty much as the one that you see here. Now, so very small, with a nurse or a clinical officer, no doctors, no medical education. So fragmentation is massive. So what we try to do at Ilara is to consolidate this hyper-fragmented space, primary care ecosystem, but using technology. So we're really building what we call the Africa primary care ecosystem for the rising middle class. I mean, the rising middle class is people who make $5+ a day, $5 to $10 a day. So it's very, very different than a rising middle class that we see in the Western world. And there's really no single solution to all those issues that I mentioned earlier, besides really consolidating the market and plugging in more solutions into the winners, the better clinical facilities, medical facilities, the ones which have the chance, because of the clinician who is a great entrepreneur, because of the location, because of the population around, those clinics will have the chance to become better clinics. And how do we do that? We started 3 years ago by bringing essential diagnostics into those clinics, literally deploying what Dr. Boniface was asking, which was, he was asking, I want to have a small laboratory in my practice. We literally bring point of care diagnostic devices or portable devices, and I'll talk more about them, and place them door to door, finance them into those clinics. But we realized over time that there's way more than just placing diagnostic devices, that the need of those small, let's call them medical SMEs, right? Because they are small businesses, they need access to capital to be able to to grow their business, to provide better care, to get educated, to provide better meds. So we've started now to actually get into financing of those clinics. And eventually, this 2022 is a year of where we're going to bring a payer. So, as much as we can improve the provider side, so the clinic, if the patient remains the same poor patients who cannot pay for the medical services, we're not solving the problem. We solve only half of the problem. So the really what we do now is bringing a payer coverage, a subscription model in this network of building that they're improving, to be able to offer the patients, based on a subscription model, better access to care. So it's really the vision here is to create a platform. We want to own those clinics, but we consolidate them to create a platform which brings essential services to drive those clinics' growth and improve the patient care eventually, which they can deliver. And this is really using technology as an enabler. As we believe that we can grow the clinic patient flow, because as I said, there are way too many, but way too small, and they don't have enough patients individually. So we can grow the clinic's patients flow and value of the services provided by plugging in more financing, more education, more assets, more devices, more medical devices into those clinics, and increasing the revenue in order to allow the best ones to actually grow and provide better services. So it's really here as diagnostic devices, portable diagnostic devices around the world. They're not built by the Philipses and the Gs of the world, but they're built by the startups sitting in the US, in India, in China, and in Russia, somewhere else in the world, and bringing those devices in Africa. So we purchase them and we place them door to door in a leasing model, because those small clinics cannot buy the $20,000 ultrasound, but cannot buy the $5,000 ultrasound either. So we need to finance those devices. And we place them door to door into those medical facilities, but we also connect them with a piece of technology. Think of an IoT type platform for us to be able to understand the number of tests that they provide, but also to understand the patient diseases and the results of the diagnostics, so we can provide the data, the diagnostic data, all the biomarkers back to the clinic and back to the patient. And really, we talk about the basic biomarkers that those patients need to get measured. Most of the issues that they have are cardiovascular disease and diabetes. Half of the people die because of those two things. And this is exactly what you can see here. Those are examples of devices. And I said there are a few major reasons patients visit those small medical centers in Africa, and those are diabetes, cardiac diseases, respiratory infections because of the quality of air, and digestive infections, and also obviously pregnancy as a condition, because women need scans, free scans during pregnancy. So our first devices cover them all. We really cover 80% of the demand across those clinics and pharmacies with just a very, very limited number of tests, and we're really moving from infections, inflammations, and reproductive health into pediatric, into metabolic health, and soon into cancer. We already do a couple of cancer markers, or each ounce, so every ounce of precision have never targeted before, and then therefore we create new markets. And this is, I mean, the growth that we've achieved is tremendous. We started with, I think I still remember early 2020, we were in 40, 50 clinics. We're now in over 800 clinics by the end of 2021, which is about 10% of the 8 to 10,000 private small medical facilities in Kenya. So massive growth. And how do we really do that? It's technology. So we started to actually power and place a diagnostic device. Now we actually go and place a platform which is more an operating system, electronic medical records to be able to onboard patients and understand then for the clinician to write these areas, but also to understand billing, which is very, very important for us to understand how much money those clinics make, so for us to be able to plug more financial resources into those clinics. End goal here, which is the phase 3. Once we've done, diagnostics, digitize the clinics, now we really understand the deeper the revenue cycle of those small clinics, and we plug more services and products to be able, and eventually the patient financing, as I mentioned, to be able to really transform an average clinic into a better clinic, into a great clinic, and also transform and also allow those patients to access a better care. And we're not alone in this game. We have support we have partnerships now with pharma companies. Pharma companies want and need to provide better medication, but they have no idea where this medication can go because there are distributors and distributors and distributors. When we understand the disease areas and we know that 50% of the people we test for diabetes markers, actually they're above the range. 70% of the blood pressure tests that we do, they are high. So does it mean that 70% of Kenyans are diabetics or have a beginning of a cardiac disease? Maybe not, but there's still a big chance. So pharma companies love this because they can provide better and cheaper medication. Insurance companies, there is no way the insurance companies penetrate those markets. I mean, Kenya has 2.7% insurance. So it's super, super small because no one knows how to price an insurance policy. So we get data from those patients and from those clinics, so we can allow insurance companies to penetrate the market. And we also have grants from the Gates Foundation we got $1.1 million last year from Gates to provide ultrasound for pregnancy in West Kenya. And so that's a massive market. We started in Kenya, but we look at other markets around Ethiopia, Tanzania, South Africa. There's so much to do. We just need time. But going back just to kind of conclude on what I'm talking, what drives us is actually our impact, our theory of change. And the way we look at this theory of change is we look at what are the inputs and the activities that we provide. As I said, we provide better diagnostics to unlock preventative care at the clinic level. We provide financing solutions, finally, by bringing diagnostics, we finance those diagnostics, we finance diagnostics, we finance medication, and we train the clinicians because, in all honesty, most of those clinicians are actually nurses who maybe studied some kind of medicine 10, 20 years ago, and they have, very basic understanding of the basic care. So we need to train those people for them to be able to provide diagnostics. So those are the inputs. Now, what are the outputs? What we really do that, right? We improve diagnostics capacity and capability. That's number one. We increase, very important, we increase the revenue of those clinics. And I know this is, we've talked about, non-profit earlier but to make this work at that level, we need to actually, everyone needs to find a gain, and many of those small clinics, privately owned, need to grow for them to be able to be sustainable because they're SME, they're businesses. We increase patient engagement and retention, very, very important. Again, there are way too many clinics. Each of them has way too little number of patients. So the winners need to actually increase their patient flow. And as I said, through this insurance model that we bring in, we need to increase the patient propensity to pay for care because 97% of the care is out of pocket. In a world where it's just 3% insured. So each patient pay out of pocket for their care, and we increase the number of patients that are treated. And the outcomes of this, there are 3 big outcomes, which are improved care for all the patients, improved quality of care. Again, there's no question of access to care as such, because there are too many clinics, but there's a question of quality. So we improve the quality of care, we improve the prevention and early detection of non-communicable diseases. Super, super important. There are more people now, the rates of diabetes and cardiac diseases is faster than the AIDS and the malaria today in those markets. And the third is that improve, chronic condition diagnostics, which is very important. People, only 1 in 5 people who have diabetes know that they have diabetes. They don't know until they get almost amputated because of diabetes effects. And all in all, we in terms of impact, we linked very closely to the SDG 3 goal, which is healthy lives and well-being for all, on strengthening the local health system and improving the health outcomes. And those are kind of a few numbers that we've achieved. We've tested over 100,000 patients since the beginning. 60% are women, 20% are actually children aged less than 5. Most of those patients are low income. We're all over Kenya, 43 out of 47 counties. We actually launched South Africa as well, very quietly now, but we're going to do the same thing in South Africa. Massive number of disease diagnostics, very quick tests in less than 10 minutes, and patients are happy. NPS is 70%. And those are the numbers that we achieved. So we had 10 clinics in the beginning of 2020. We're more than 800 now. Same like 500 tests carried in Q1, 100,000 now, and clinics, very important, clinics to me data, because those diagnostics are connected. We start to get data from the devices. We had very few diagnoses connected back in 2020. Have more than half of the clinics where we are. And then again, we're aligned both with the Global Health Organization policy, which is health system strengthening pillars around the service delivery, the health workforce, or education of the workforce, information, financing, medical products, but also on the vision 2030 in Kenya, which the big four, what the Kenya government calls the big four, includes actually affordable healthcare for all. So this is just to summarize our what we build at Ilara is a company that bridges the diagnostics gap, also improves the quality of care overall across Africa. Our mission is to redefine primary care from the beginning, from the basis across emerging markets, not only Africa. I mean, we're starting in Africa, but we're going to move into other places, hopefully in the future, by bringing those novel diagnostics and digital solutions to healthcare and to patients, with the visions of, I really dream of the world in which early detection and prevention are accessible to everyone, everywhere. And, we've achieved a really good scale, which we continue to grow in 2022 and above. Thank you so much.
Thank you very much, Emilian. That was really, really insightful. And it's just extraordinarily impressive to see the exponential growth to go from 10 clinics to, I think you said, was it 800?
Exactly.
Yeah, in just, I suppose, under 2 years is incredible. And as you were saying, to actually really focus on early detection, it really, really makes a huge difference. So we're not dealing with crises after the fact as well. So thank you so much for such an insightful presentation. We've had so many compliments in chat as well. We've got Yulia, who's complimented you on saying that you're doing an incredible job. Several people thanking you for your presentation and the work. We do have a question in Q&A, which, if you wouldn't mind, if we were to pose that direct to you now, if that would be okay.
Sure.
It comes from Michael Ahiampong, I think, and he would like to know, firstly, obviously it was an inspirational presentation. Are you partnering with NGOs, local ministries of health, etc., in the 5 key markets in Africa?
Yeah, so we're in, first of all, we're in Kenya. I mean, we just started South Africa, so we're not yet in 5 markets. We're in 1 plus 1.1 markets. Look, through the Gates grant, Gates Foundation grant, which we got last year, the goal of the grant was actually to bring remote care for pregnancy scans, so remote pregnancy scans analysis in public sector in West Kenya. So we are partnering with the public sector, not with the government as such, but with public hospitals and public clinics, public dispensaries, with the goal of, during COVID, women did not go anymore to get scanned for during their pregnancy to hospitals, because people just stayed home. So our goal with the Great Gates grant was, can we bring ultrasound scans from the level of the big hospitals down to where the people live, which are those small dispensaries. So that's what we're doing now. That's remained limited to a part of the region in Kenya, but really the goal here is to, because a private care is half of the care. 10,000 primary care facilities, public, it's a complex sector because there's no financial incentive. We need to go to the local counties, and it's a federal system. You need to go to each county separately. So yes.
Wonderful. Thank you very much. There was another question that he did ask, which actually ties into something that you probably will get asked a lot. And obviously, given the pandemic and given COVID and just the rise in so many different variants, and obviously the topic at the moment is Omicron as well. How has that affected your work? And is it actually a focus or an area of focus for Ilara at the moment? And for example, being not just the kind of care around that, but the distribution of vaccines as an example?
Look, I think COVID in general for healthcare has been, as bad as it's been for providers and for individuals, at least has raised awareness that care in Africa has been for 50 years publicly financed by public sector, by NGOs, by grants, by free money. And the reality where Africa is now in terms of healthcare, it's also a result of the way those money have been distributed and used, right? So COVID came, and then investors and governments and private organizations and public organizations realized that we need to look into changing this in a way, right? So COVID has been good for us to a certain extent, has been bad for those small medical facilities because people stayed home. I still remember May, June last year. But what's interesting is that in those markets, people are extremely resilient. Businesses are resilient. If those small clinics, there are 20,000 of them, and another 40,000 pharmacies, if they don't make money by the end of the day, the owner, because it's one-man show, the owner goes home and doesn't bring a bread to their kids and family, right? So they turn around immediately. There was 1 or 2 months where they lost some patients, but they emerged immediately out of it. And I still remember June, July last year, I was going to those areas, to the middle of COVID. There was people were in the street, people were working, with masks, but business was as usual because they need to do it. It's not, they can't stay home and then get government help like we would do if we were in Western Europe, right, or in North America, right? Those people need to make money. So COVID has been, we're not. I don't think doing just PCR tests is the future. I think we do antigen tests, and antigen is the new standard, and we do that in corporates. We do that for those that safely go back to work in Kenya. But again, COVID comes, and COVID came and then will go or will stay to a certain extent. People die of diabetes today. People die of heart attack. People die of cancer. No one is talking about this. Everyone is talking about COVID. Yes. If you look at the numbers, the reality, more people die in this world because of everything else than COVID, right? So I strongly believe we're not here for COVID. We're here for every disease which affects those individuals for the foreseeable future. And non-communicable diseases are actually what I believe we need to target.
No, I think that is a very, very good point to make. And naturally, I think we would all automatically react to ask you questions directly about COVID and your response to COVID. But, you made a really important point earlier, which we should all bear in mind, is that COVID has come in as a hurricane across the world, and it's affected how everything is done and the delivery. And the example you made, in providing sort of ultrasound capabilities to pregnant women closer to their homes is a really good. I was pregnant during COVID, and for me, I dreaded going. And I was fortunate to have, the technology and the actual healthcare that I have on my doorstep. So I can only imagine how difficult that would be for pregnant women in less fortunate areas. And I think it's absolutely incredible that you're identifying needs that are also impacted by COVID and the actual restrictions that they put upon you and just everyday life. So I think that you're right. Cancer is there, diabetes is there, all these, people are still being affected, and all we are doing as, society and yourself as well is optimizing around that. So just a huge congratulations to the work that you're doing. Thank you very, very, very much.